my screen. I have prepared a few slides for this. So now I have my screen. Okay. So how to prepare for the FRCS for general surgeons. And we will give a little bit of perspective from colorectal and upper GI. To start with, these are the aims of this presentation. We are going to discuss the eligibility criteria to take this exam, how to book the exam, what is the format of the exam, both part 1 and part 2. We will talk a bit about how the exam days work, what to expect on the day of the exam, and then we will give our experience about how to prepare, what resources to use, and that sort of thing. We have a couple of slides about how the exam is marked, because I think it will help people to focus and understand what's the different weights of the different parts of the exam. And then finally, we'll talk about some final tips. So we aim for this to be short and effective as possible. So to start, I'll start straight away with the eligibility criteria for to get to the exam from the start, and this is marked as completion of phase 2 of the new curriculum. For people who are aware of the UK system of training, that's when you finish ST6 year. So you get an ERCB outcome 1, so you pass your ST6 year, then you'll be allowed to take the exam. Without this, you will not be signed off, and you can't take the exam. If you are a non-trainee or overseas, you're not practicing the UK, then you need to get references and a lookbook to demonstrate that you have equivalent experience to an ST7. So that's a level of training in the UK. And this is to say that you are at a consultant level from a general surgery point of view, and you're ready to specialize or subspecialize in either colorectal, upper GI, HPV, and so on. So when you are at this level, proved by references and lookbook, then you'll be allowed to take the exam. So this is the eligibility. And how does it work? How do you book the exam? It's really simple. You go to the GCIE website, you create an account, and then you will download the structured references from the site. These references will need to be filled, 3 references from consultants you recently worked with. They simply will testify that you are at the appropriate level to take the exam. You will be also asked to upload your logbook again to demonstrate that you are at the right level to take this exam. For trainees, one of the referees should be your TBD, or at least that's recommended, that your TBD will be one of the referees. For non-trainees, the guidance is that the head of the department or the clinical lead should also be one of the referees. So that's the guidance as well. So that's something that you need to bear in mind. At this point, when you're booking, you will need to pay for both parts of the exam in advance. Also, you need to notice that the deadline for paying for the exam is usually a couple of months before the exam itself. So you need to watch out for the dates closely. Also, at this point, when you're booking, you will be asked to choose a subspecialty. There's no general surgery anymore. So you have to choose colorectal, HPV, or OG at this point. Some people manage to change the subspecialty after exam the exam part 1. So, for instance, they declared that the colorectal after part 1, they wanted to change to upper GI or HPB, and then there is a process, but this is not the usual thing. So it's better for you to be settled on a specialty or subspecialty before taking the step to book the exam. Mohammed, do you want to talk a bit about the format of the exam, the part 1, part 2?
Sure. So thanks, Mohammed. Well done, and a very good overview. The exam part 1 is the paper exam, paper between commas. You go sit in a computer at the View Pearson Center where they do the driving test, and you take 120 questions of MCQs twice over 2 papers, with the rest time in the middle, about 2 hours with the rest time in the middle. It covers basically all the broad minutiae of the FRCS curriculum. Anything that can happen. They bring pictures, they bring scans, they bring CTs for livers if you want, or breast imaging, things like that. So be prepared to look at these things and interpret them during the exam. The second part is the clinical examination, and this is a viva, essentially, an oral exam with 2 examiners, one's marking and one is giving the questions. And it covers the whole breadth of general surgery as well as your special interest, specialty of interest. There may be, we're just discussing this, they might reintroduce a live examination of patients or volunteer actors. However, in our recent experience, it was all viva and describing what you would do, and you would be given the findings that you're asking for, essentially. So be prepared that you might be asked to examine patients once more. They cover everything in general surgery. I got asked appendectomy. I got asked 3 thyroid short cases. And I was in the old curriculum for upper GI, so I covered HPB and OG. And then as an OG trainee, I got asked a distal pancreatectomy case. So be mindful that you might get asked these things, although now that you're split to OG or HPB, you should be well within your lane. We're also discussing that the general surgery short cases are probably the most valuable in terms of points per time, as they gather more points, or could be an opportunity to gather more points in a short space of time. So something to think about as well.
Yeah.
Next slide.
Next slide is about the oral examination as well.
The oral exam, the stations are well organized. It's half an hour. Every station is half an hour. We cover emergency surgery, critical care, trauma, general surgery and clinical practice, the principles, general questions, special interest, that's a short case. And then the special interest again, it could be a long case or applied anatomy. And there's an academic station which they essentially give you a paper to critique and discuss the learning points out of that paper and do a critical appraisal of the paper. So essentially, it's things that you would be comfortable doing on a day-to-day basis, and it's all at the level of a day 1 consultant. So we'll talk more about how to answer the questions and things like that, and further down tonight's presentation.
Yeah, I just want to come back to part 1 because I don't know about you, but I had the feeling, and I asked some people as well, colleagues, about this, and it sounds like the part 1 exam sometimes comes themed, as in you will have more questions about one specialty. So for instance, I had a lot of breast questions. I'm a colorectal trainee, but I had a lot of breast, and I've asked other people, and then they said yes. Sometimes it comes with vascular themes, or sometimes comes with colorectal themes. So you could get this, and you'll be caught out.
I think we had the same exam. So mine was a breast MDT. Every 5th question was a breast question.
Yeah.
And the same exam also had lots of HPB trauma and HPB emergencies. Yeah. So got liver abscesses, amoebiasis, liver trauma, how to handle it, METs. So yeah, I agree with that.
Yeah.
But then
also that what makes part 1 a bit annoying, actually, because as a colorectal trainee, I haven't done much of transplant, for instance, and then you get a lot of questions about transplant, and it can be very annoying. And I think, in my opinion, part one is the part where you need to revise more and get more knowledge, and while part two is more about the presentation.
I agree. Part one is more knowledge. Part two is technique.
Is technique, exactly. And we probably will talk about this a bit more, but for now, for part one, it's very important when you're preparing to try to find out your weak points. So for me, when I started revising for part one, I was very, very weak in breast and vascular, because I was very focused from the start of my training on GI. I haven't even done a breast job. So I was very weak and when I started revision, and then I focused. So it's very, very important when you start your revision to try to identify these weak points, so you can revise more and strengthen your revision on these parts. Because as we just said, and this is what exactly happened to me, I was very weak in breast, and my exam came a breast themed exam. So you need to be really careful with this point.
I agree with you. And I can recommend a few ways of how to address these points. So I didn't start with focusing on a particular topic. I did one of the question banks all the way from start to finish. Obviously scored about 40% success.
Yeah.
And then it gives you the breakdown of where your weakest points are. And you also record where you feel what your weakest points. And then we can talk about later on how to address things, for example, cancer in general.
Yeah.
Don't get bogged down in the guidance, and don't get bogged down in the studies and the papers.
Yeah.
And you'd be surprised how simple, although the NICE guidelines are very simple and very almost intentionally vague to pin you down to a specific thing to do. There are a good starting point, and then you can build from them. Once you understand them, build from them on what other things that you need to read on. So we'll discuss that later on. But yeah, I agree with what you're saying.
Yeah, agreed. And then we talked about the again the clinical examination and the Viva. It's more about the presentation and how you present yourself, how your time you control your time and control your stress rather than the knowledge itself. So so the next slide is about what to expect on the exam day. So in part one, it's just it's just you go to the exam center, as we said, just be an ID check. Then you sit on a computer and do a session, 2 hours, 15 minutes. Then you get a break, about an hour and a half. Then you come back, you do the second paper. There's nothing really special about it. But obviously, the time is very tight, so you will need to be very quick. And part of your preparation should be that you are that you time yourself. In my opinion, you need to time yourself while answering the questions, because it's very the time is very, very tight. I think for these exams, you don't have really much time to think. You either know it or you don't know it. And I don't think you should waste a lot of time in questions that you don't know. If you don't know the question, just pick an answer and move on, because you won't really have much time to think about the questions. Do you think what do you think about that?
I think agreed. I think if you divide the time over the number of questions, you end up having about 50 seconds per question. So when you're revising, you're aiming to get rid of every question within 40 seconds. Yeah. You end up having quite a lot of time, actually. You end up having 20 minutes or something to revise.
Yeah.
And the platform that you're doing the questions on at the exam center allows you to mark the questions that you're not sure and you want to come back to.
Yeah.
So I agree with you. If you want to kind of gain a lot of ground in the first half hour of the exam, gain your momentum, gain your tempo, and then you also need to increase your own confidence as you're taking the questions. So don't get stumped. Don't waste a lot of time answering one question. it's 40 seconds. So either, like you say, either you know it or you don't. Sometimes if you sit reread it, or the nerves calm down and you reread it, or you'd have solved one more question that would have reminded you of the answer of the first question, then you can go back and do it, but don't waste a lot of time. And if you time yourself to solve each question within half a minute or 40 seconds, that leaves you a lot of time in the end to revise the questions that you're not sure about.
Yeah.
And the other technique that I used to do in that exam is read the last line of the question first.
Oh, that's interesting.
So they'll ask you, 28-year-old woman with family history of endometriosis, and she's got a cat, and she's went to Portugal, and whatever, blah blah blah. And then you interview like, what's the commonest cause for her raised bilirubin or something like that.
Yeah. So sometimes there's a lot of jargon in the middle that you
Yeah,
don't really
yeah.
need to answer the question.
So you need to. Sorry, 1 second, guys.
ماشي، همنتج لكم الحتة دي، مش مشكلة.
That's okay. So while we're waiting for Mohammed, I'll talk a bit about part 2 as well. So part 2, the exam will run over 2 days. It's usually you will usually receive your schedule well in advance. You'll have some of the sessions on one day, and then the rest of them in the next day. There is a lot of waiting time between the sessions, so you have a session, then maybe 2 hours before the next one. So there'll be a lot of time between these sessions, and that's exactly why you should be book in a comfortable place in the hotel, and maybe even in the venue where the exam is taking place, or very close by. The dressing code is formal. You need to be very formal, suit, or at least smart dressing code. The exam days for part 2 are very, very well organized. Usually, it runs very well. It's very professional, and there are different places, but usually the venue is very nice as well.
Sorry about that.
Yeah, that's all right.
So I'd agree with all of that. I would say don't try to travel not the night before, the night before. So spend one night there, and then you wake up the day before the exam. So you don't have to worry about travel, especially if rail disruptions and motorways closing and things like that. You don't know. So just minimize the risk at all times.
Yeah.
And I agree. And dress formal. I don't. You stick out. If you're the only one without a suit, you stick out.
Yeah. Everybody's in a suit. Everybody is looking very smart. So you have to be the same. Yeah. On the day of the exam itself, you will be invited to sit in a waiting area. Then they will ask you to go to another area where there are chairs, and you will get in a queue. You have a number. You get in a queue. And then once the examiners are ready, you go in your queue, and then you sit with your examiners for whatever is clinical, short, long cases, or the vivas. You finish the session and you just leave straight away. Usually for each session, long, short, or viva, you'll have 2 examiners usually. Sometimes there is a third person who's just an observer, but usually you got 2 examiners. And usually one of them will be asking the question, the other one will be marking, and then they will alternate. So somebody else will ask some questions, the other one will be marking. The time is very, very tight again, so you need to be very, very slick. And we'll talk a bit about in the next slide about how to prepare and how to answer. But as we said before, you're supposed to present yourself as a colleague, not as a registrar, but as a consultant colleague. You should have this attitude, and this is what they're expecting you to present yourself as. It's all about how you present yourself, what's your attitude, and to show that you are a safe pair of hands, and that you are confident of what you're saying, and you can justify what you're saying. As we said, it's not about the depth of the knowledge; it's more about the breadth of the knowledge, and having some safe approaches and safe answers and safe ways to get out of trouble.
I totally agree. One of the American podcasts had one of the Canadian surgeons on, and they were basically saying they want you to be humble but confident.
Exactly.
And you're talking to a consultant colleague in the coffee room would be the best way to describe it. You're being professional, you're being courteous, knowledgeable, but at the same time, not showing off, you're not being too loud or extravagant and things like that. Shall we move on to the sources? Because this is the bit I'd like to, looking forward to
resources.
Discuss.
Yeah, let's go to the resource. So the resources, the exam preparation, we'll talk a bit about what are the resources, how to prepare for the exam. For part one, for me, in my experience, part one is all about question banks. You do as many question banks as you can. These are the ones that I did. FRCS Companion and higher FRCS. These are the one I did. There's the BMJ one, which is a bit more non-specific. I didn't really like it. It's not really specific to FRCS, but these ones are pretty good. And I think it's all about doing the question banks over and over again until you're very slick, very quick, and you have all the knowledge that you need. Other people read books and textbooks and that sort of thing. In my experience, there's no time to do this. You're doing your exam on the job. You're in a full-time job. Most people will be on full-time as you prepare for the exam. And I don't, in my experience, I didn't have time to do a lot of reading. I just did the question banks over and over again. And then when you get a question that you're not very confident about, then you refer to a specific bit of a textbook or a guideline or whatever to gain that much more knowledge about this specific area. So this is why I did the question banks, and then when I feel that I need to know a little bit more about a specific topic, I go and read a bit more about it. But that's selectively rather than opening a textbook from start to finish. I don't think there will be time for this.
Agree.
What's your experience?
Yeah, I think if you manage to get 2 hours a day of revision, then you'll be winning. You'll be laughing. I pretty much did the same resources. EFRCS, I did it twice. FRCS Companion, I did it twice. There was a PDF going around doing the rotations from a group in Glasgow that had extended matching questions and as well as single best answer questions.
Yeah.
And the level of detail that this book explored was very good. So it might be worth getting your hands on it. It's very good in terms of polishes your knowledge and really good at identifying the gaps. What I did differently for part one is I studied with a colleague. So I studied I did the questions, we did the questions together, and we'd match our scores, and we'd also revise the questions that we got wrong and explain them to each other.
It's a very good idea for part one and part two, or obviously to have a mate or somebody to revise with. That's a very good advice. If you can get a group, even one, that'll be very very good, and it'll be very beneficial for part two as well, especially if you get the opposite subspecialty. So if let's say you your upper GI or HPB, if you get a colorectal mate and you revise together, because you have to remember that you are going to get questions from the other subspecialties as well in the clinical and the Viva. So you have to be prepared for that. And when you get if you get to revise with a colleague from the other subspecialty, they will have better understanding of some topics, and they can give you a very valuable feedback. This is what I think.
I agree. My study group was another upper GI colleague and one colorectal colleague.
Yeah,
and it was very good from that perspective. And you have to be ruthless with each other.
Yeah,
you have to. This is your only opportunity. You have to be mean to be kind.
Yeah, that's right.
And it's good memories later on, but at the time it'll be fun. And it's also good if all of you book the exam together and travel together, because you're keeping that at the same time. My study group, we started. One of my colleagues had the exam with me. We're in the same stations pretty much, and our colleague started the second half day after we finished, so that was good. And we all passed in that exam, so
that's good.
It's I didn't take any courses, by the way, but it's always beneficial to have one of your colleagues go to the courses. So both of them went to the other two courses, and then we reconvened.
That's very good.
So I totally agree with what you're putting in bold there. It's practice, essentially. You put away 2-3 hours or 1 hour a day when you're working, and you have kids, and you put them to bed, and doing the dishes and whatever, and you have dinner. So you have like probably if you have an hour between 9 and 10, you're lucky. You do that 5 times a week, you're laughing. And no one has more time than that, and it doesn't need any more time than that.
And for me, I took a few days before the exam as well. So I think I took the week before the exam off as study leaves to have this final, focusing, concentration, and just fire through the question banks quickly, and then you get in the mood of going through the questions quickly, because this is what you're gonna get in the exam day as well.
I agree, totally agree with that. Just reiterating the bit about the guidelines, I would say nice guidelines in British and UK societal guidelines are a must. If your specialty has a BSG or OGIS or ACP GBI landmark papers and position statements, then you need to know them. And then overarching are nice, and you don't really need to go beyond that, especially unless if it's breast, for example, and you're not a breast trainee, then you need to follow what NICE says, or there will be summarized European Society and American Society of Breast Cancer guidelines that you need to follow. And the other book that I really recommend was the Landmark Papers book.
Okay. So talking about books, so books for the we're talking about part 2 now. So for the books, you said the landmark books,
That's the only book that I recommend.
Okay.
Cracking was nice.
I didn't read that one, but that's interesting. That's
cracking
good.
The FRCS was good, and higher companion, the FRCS companion book was very good. The new edition's out as well.
And you can get the companion you can get to the companion series through the Royal College website. For free.
So you don't need to buy all like 15 books.
So the companion you can get from the website for free. So that's a good thing. I have to say I didn't go through. I didn't read all the books, the cracking and the companion series. I didn't read all of it. I read maybe half of it, 70% of the books on the the topics that I felt that I need to read, but I didn't do all the reading for the books. I did some more reading, as you said, about the guidelines, the NICE guidelines, the BSG guidelines, and things about the colonoscopy, and the polyps and that sort of thing. I read the ACGBI and BSG guidelines. So these are important for sure. I read a couple of recent papers and when it comes to cancer management and rectal cancer, that sort of things, just to, you know, to be up to date. But you don't really need to do this. You don't
Yeah.
need to be to read the latest evidence or anything. That's if you want to get 8s, and we will get to the marking in the next section. But as you said, it's if you have the guidelines, you need to read them. You need to know the recommendation from these guideline bodies, and then these books will give you an overview. And as we said, it's more about the breadth rather than the depth of the knowledge. There isn't really much time in the exam for them to go very deep on one specific topic. And that's why, you know, there's no point being a super expert in one topic. You just need to know, you just need to be safe and know the general practice. Yeah.
Agreed.
Yeah. And then for me, after the books, there is the websites. So for me, I did the FRCS Viva because it's actually strong on colorectal. I'm not sure that it's not as strong in AbdalKoddus, I don't think. Maybe they have they updated it, or it's now more developed in terms of covering AbdalKoddus, but it was very good for colorectal. It's a website, as you know, it's again, you register an account for 3 months, for 6 months, for whatever, and then it gives you a scenario and gives you a model answer and what you will actually say. And it's the questions are actually questions that came before in the exams, and I have to say that I got a couple of questions exactly in the exam, and other people had the same experience with this specific website. Other people said about higher Viva as well. This is a new one, but I haven't really tried that one. For me, a big bulk of my revision as well was the Behind the Knife podcast. I was commuting at the time, and I used to listen to it in and out of the hospital. But you need to be a little bit careful with Behind the Knife because it's American, and they will have sometimes they will have some different guidelines than the British ones. The big example will be rectal cancer management. The NCC guidelines, the American guidelines, are different from the NICE guidelines. And it's fine if you say what they say in the exam and you can't justify what you're saying, it's fine. But you just need to be a little bit careful and know what you're actually saying, and notice that there is sometimes there is a difference between what they're saying and how they practice in the US and Canada and how we practice here in the UK. Again, for another example of how, from colorectal point of view, is management of PR bleeding. They do a lot of emergency colonoscopies, while this is not really a widespread practice here in the UK. So you'll find some of the things that they say is more reflective of what they do in the US and North America rather than in the UK. So it's a great resource, but you need to be a little bit careful with it when it comes to these differences.
I agree with that. They can get a lot of technique out of them and how they summarize things and how they demonstrate their knowledge without sounding too cocky or too overconfident. But I mean, you should marry it up with your own knowledge of the guidelines.
Yeah, I think it's a great resource, really, and especially if you're commuting, if you have time, if you running, you doing sport or whatever, you can use this time to listen to their podcast. It's really good.
With one of the websites, can't remember which one, I think it was the FRCS Companion, had also a group of Viva questions that we found were very useful. We resisted my group and I, we resisted the temptation to subscribe until like 2 days before the exam.
Wow.
So we then like joined this thing,
Yeah.
and then we were in Glasgow reading these random questions off a website the night before the exam. So that was, don't recommend that. But the questions were good. The questions were good revision. Good revision tool.
Of course. When it
Even
comes
on
to
the
courses,
course?
I didn't do the courses, and a lot of people didn't do the courses. When it comes to courses, they are expensive, but they are useful to some people. There is also I think there is the option that you go as an observer rather than taking the course itself and be a candidate. So you didn't take the courses either, did you?
I didn't take the courses. I could
Yeah.
barely afford the exam.
Yeah, exactly.
Yeah.
They are very expensive, and it's not a must. But for some people, it's just to get out of your daily routine, and if you have kids and you can't focus and that sort of thing, you take a week off. You are out of the house, so you have to focus. There's not much more you can do but actually study and practice. So for some people who are struggling to revise at home or take some time off or whatever, then it could be a good idea, but it's an expensive option.
Yeah.
Yeah.
Agreed.
Yeah. So we come to the most important way of preparation, and we already touched on this about the exam groups. And even if you don't have a study group, it's very, very, very important for part 2 of the exam to have timed practice sessions, both with peers and consultants or seniors. So what I didn't have a study group, but what I did, I had a schedule where I had like 6, 7, 8 different people, and I'll take every day there'll be one of them having a session with me for half an hour, 45 minutes, nothing much, One of them will be a fellow, one will be one of my colleagues who recently took the exam, and sometimes one of the consultants, sometimes in the hospital after theater or between cases, just to, fire a random scenario at me or whatever. And sometimes over teams like this, in the evening after you go home, you get your tea, you sit down with a colleague, and they just, prepare a couple of scenarios for you. And this is why I did. And it has to be timed, and you have to do all the different times. So for the vivas, you need to do the 5 minutes. You have to do short scenarios for 5 minutes. You have to do slightly longer scenarios for 10 minutes with our short cases. And you have to do longer scenarios that spans 20 minutes. Because it's different. The technique for preparation for these different parts of the exam, the short, long, and the viva are different. And you need to be strategically prepared for these. For instance, for the vivas, it's only 5 minutes. You don't really have time to waste and go about detailed of the history taken and the examination, that sort of thing. There's no time for this, and you'll be surprised how fast the 5 minutes go. It's not really long at all. And then for the short cases, you adjust a bit more. You give more details on your the history and the examination, and a bit more about your differential and that sort of thing, but not too much because again it's only 10 minutes. And then for the 20 minutes for the long cases, you can relax a bit more and cover more details. And we'll see on the marking that you get more points for these different parts of your answer with these different questions. I don't know, what do you think?
I agree totally. Timing and making sure you don't waffle in your questions and your answers are clear and concise. You're showcasing, you don't want to donate information you don't need, and you don't want to show any weaknesses, but equally you want to demonstrate the breadth of your knowledge in terms of a topic, especially in a short case. So this only can come with practice when you mention the specific points that you have to mention in order to get the points of the question, and then also enable the examiner to pick up on the things that you're saying and to ask you further questions. If they keep asking questions, it means that you're doing well.
That's a very good point, actually, because this is a question that I had, and many colleagues. I don't know which is the best approach when it comes to this. is it better if they introduce the first question that you just carry on and keep talking and talking, you know, and you know, you say, if this happens, I do this. If that happens, you do. Or is it better for you to answer very concisely and ask, wait for them to give you more clues? What do you think?
I think it's the concise way is the best way. That's how I used to practice, and that's how I do another podcast on the FRCS preparation, and that's how we tailor the questions. And the answer. I'm going to examine the patient, take a relevant history. I'm mainly worried about this particular differential diagnosis. With that in mind, I'll ask about these key things in their history. I want to do an exam, I'm looking for these particular findings. I want to go look at the blood, I'm looking for these the results. Things like that. Because they're not going to catch you. There are a few things. So like they have a CT scan. The trick in the CT scan, for example, is that the cecum it's a cecal volvulus, and rather than the cecum being in the right upper quadrant, it's in the pelvis. That's the whole trick. And if you know that if you notice it's a cecal volvulus, then that's it, you're flying. Because the rest of the questions is, all right, how are you going to fix this? Are you going to join? When are you not going to join? What are the options? Things like that. And it's lots of to and fro. And they know at this point, you know, they know you're safe. They know that you've made the right decision to take someone to have a laparotomy. They know that you can. It's now, but it's getting to that point and getting to that flow. Sometimes there'll be, if you're not getting to that, I had a station. I didn't know enough about the question, and I was like, the examiner looked me point blank in the eye and said, "I'm sorry, but you should know this. This is not good." So, short, concise. This is what I think is going on. This is what I'm going to do. Blah 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 blah. If you're going completely in the wrong direction, if you answered the short, concise answer, then you have time to retract that and then recorrect your course and start in the right direction. If you've been waffling on for 2 minutes talking, if it's this, I'm going to do this. If it's this, I'm going to do that. Then how are you've wasted your time.
And then what do you think about the other thing that again was a bit controversial? What do you think if you are AbdalKoddus, for instance, and you get a colorectal cancer case, whatever, in your general surgery, because you can have that. Some people I asked, they said, well, we give the general information. I think this is what will happen. You know, they will need to be staged and whatever, but I'm going to refer them to colorectal. And then the examiners kept saying, but what do you think colorectal will do? And they said, well, I think they will do this or that, but I'm going to refer them. So do you think it's safe if it's a different specialty and it comes to a specific question like this, like cancer, to just refer to the other specialty?
This will fall in the realm of emergency. If you get you're the on-call emergency surgeon. And a perforated cecal cancer turns up. I'm an upper GI trainee. Okay. And a perforated cecal cancer turns up. Patient's sick. What are you going to do?
No, but that's fine. But for instance, for me, I was colorectal. I got a patient in the outpatient clinic, not an emergency. With weight loss and iron deficiency anemia, and they had an OGD, and if or I said we'll get an OGD, I think, but the short of this, that the case was an OG cancer, you know, OG junction, the gastric cancer, and then, well, this is an elective case. What do I just say?
Not necessarily.
I'm going to manage it this way, or do I just say, well, it's AbdalKoddus, I'm just going to refer them to AbdalKoddus? Because in practice, this is what you're going to do.
Not necessarily. You can either, because the referral to upper GI is different pathways. In this situation especially, because if they are losing weight and they're not keeping any fluids down, this needs admission and you refer them internally to upper GI. If they're managing solids or they need a different situation, then that's a different scenario. If they're not, if they're managing liquids, if they're managing solids, if they're lost a little bit of weight, but they're maintaining their weight, then they can wait and they can get through the MDT and through that stuff. But that's the situation. What the upper GI, and I doubt that, is this what you got in the exam? You got an OG cancer case.
And I can tell you they even asked me about chemotherapy. what chemotherapy you would give. I said, well, I'm not going to give chemotherapy, but what do you think they will give? And I knew that there is the float thing, so I've told them float, so it was fine in the end. But
Well,
what
if
I'm
you went
saying
that
here
far
that
as a
even though
colorectal,
that I was colorectal, I got a gastric cancer, and because I did well with the first part of history taking and the
yeah.
initial examination, investigation, that sort of thing, they pushed me all the way to staging, and then what after staging, and what is it going to be, surgery first or chemotherapy first, and then
I'm gonna ask
what
you-
type of chemotherapy you will give as well. If you're answering, they just push you and keep going.
He's gonna ask you next the benefits of robotic versus laparoscopic in gastric
Exactly.
cancer.
So
Sounds like you.
this is what I'm saying. At what point you say, well, I don't know, I'm just going to refer to OB/GI. It's not my specialty.
There are certain, so you can't always. I think you did very well to get that far, and you clearly were doing very well. That's why he was pushing to give you the 8, to give you the 8. But I think that's not how the way. So I think that's not the right example for that thing. But I think the right example would be, for example, in a diverticular perf.
Yeah.
I'm a like a bad diverticular perf, septic, needs a resection, needs a washout.
Yeah.
I'm an upper
That's
GI.
general surgery. Yeah.
Yeah, I'm an upper GI consultant or day one upper GI consultant. I'm gonna do a Hartmann's.
Yeah.
Leave it at that. You then have to say, well, we're gonna assess the patient and think, have a bit of an MDT. I might call a friend, but in my mind, I'm thinking the options are I'm gonna do a join and defunction, or do a Hartmann's, or do a washout, or do this, or do that.
Yeah.
That I think that's where the difference comes from.
Yeah.
And I would also say, and because that's what I would say. I said, in my hands, Hartmann's is the safest option, but I'm aware of the other options such as washout, primary anastomosis with defunctioning or without defunctioning, as per evidence by the ladies' trials, the Lola and the Diva, and you can make of that as you will.
Yeah. Great. Okay, so moving on. So next, this is how the actual exam is marked. So this is a demonstration how they mark. So obviously you get marking episodes. So a short case, you have 3 A, B, and C marking episodes. So 3, 4 to 8 marking, and so and you will be marked as I said, from 4 to 8. 4 being the worst, and 8 being obviously the best. For all the short cases, we'll have 3 7s or 3 8s, so three marking sessions. Yeah. So in 10 minutes, you get 3 marking sessions. While for the long case, if you look at the bottom of the slide, the long case, it's 20 minutes, but only 4 marking episodes. So for a long case, the maximum will be 32 points in 20 minutes. While for the short cases, it's 10 minutes each. So for both of them, that will be more. That will be 48 marks maximum. That's 8 times 6. Yeah. So that's why we say what we meant about that the short cases have more weight by time. And as you can see, for the short cases, you get 1 marking episode for history taken examination, 1 for investigation of differential diagnosis and treatment options, and then 1 for complications on communication and consent and that sort of thing. Is a little bit different for the long cases, where you still have the history and examination for 1. Then you get the investigation and clinical knowledge. So they want you to speak a bit more about the investigation and the treatment, because the treatment options are a separate point for long cases. And then the communication skills and the consent and the professionalism is a different marking episode. So you can see what we were saying about for when you're revising, when you're practicing for these, you have to have different strategies for preparing for the short cases and the long cases. Because for the long cases, you give more details on each of these segments and expand a bit more about the investigation and treatment options. While for the short cases, the investigation, differential diagnosis, and treatment options all are gathered in one marking episode. So you don't have time to talk in much more detail that you like for the short cases. And this needs to be reflected in your preparation as well. Do you have anything to add here, Mohammed, or shall I move to the next one?
That's pretty much it.
Yeah. For the next one, this is how the vivas are marked. So it's you get 4 by 6 vivas. So 4 sessions. Every session will have 6 vivas. Each viva question will be a 5 minutes, and it's really quick fire. Quick firing questions. There is no time whatsoever to go into any detail. There'll be a question about a presentation. You get to a differential diagnosis. They tell you this is the investigation that you did, or this is the differential diagnosis. This is what the diagnosis, what you're gonna do, and they move on quickly. It'll be very quick moving on exercise, and you need to be very slick and on it. And it's sometimes difficult if you did one of the vivas badly to get out of this mood, and you'll still be thinking about the first or the second viva that you did badly, and then there's no time to recollect yourself and and get out of stress and focus on the on the second one. And this is where a good practice comes handy. Your friends or your colleagues or your consultant you're practicing with will need to be mean to you, or a little bit mean, a little bit rough and tough with you to prepare you for this, because every now and then you'll get an examiner who's a bit tough. And then if you get this on the viva questions, there is no time for you to recollect yourself, as I said. So you need to be well practiced, well prepared for this, to just put it behind you and focus on the next question. And as you can see here, there's no much detail about history taken or whatever. It's just a one marking episode, and it will be quick, really very quick firing. Anything to add, Mohammed?
No, I think it's perfect.
Yeah.
Don't let one bad station put you down. That's basically it.
Yeah, exactly.
I'm sure every hospital has one consultant who will tell you the story. Oh, I did this bad station. I walked outside. Then leave the exam, and then the president of the examination board brought him back inside, and he passed the thing on the day. So don't let one bad station, because you can easily make it up with a handful of good ones as well.
Yeah, and as you can see from this marking, the aim is to get 6s and 7th. 7th, 8, yeah, occasional 8s are nice, but usually you'll get 6s and 7th, and if you get 7th, that's really good. So the 4 and 5, if you pass the very basic questions, the initial 2-3 questions, then you're pretty much in the 6 zone. Yeah. And then if you add some more detail, you got some more evidence, you're talking about 7th, and then if you mention studies and that sort of thing, then that's an 8. But most of your sessions will probably be 6 or 7, where you pass the very basic question, you demonstrate that you're safe, that you know about the topic and how to approach it, and then if you know a little bit about the complications and how to get out of trouble, and this will get you into a 7 zone as well. And then if you know the evidence, the guidance, or the papers and whatever, then that's an 8. but this is not necessary. You know, if you get a lot of 7th, then you're probably guaranteed to pass the exam. I'll pass on to the next one, which is the marking descriptors. How do the examiners decide how to give you a 4, 5, or an 8? Yeah, and this is how they decide. This is the descriptors. Sorry, it's not very clear. I can actually share the other one here. So that's hopefully a little bit better. You can see this a bit more. So you get marked on 4 different aspects. Only one of them is the basic knowledge, and this again, this is why we what we were talking about, that the second part is more about yourself, your attitude, and how you're approaching things rather than a deep knowledge about the topic, because the knowledge is actually only one aspect or out of 4 how you get marked. The others are how the second one is high order processing, which talking about how do you apply this knowledge that you know about this specific scenarios, and when they twist the scenario a bit, how do you respond to this? And then the third aspect is about your history taking examination, which is not a knowledge. It's just how you practice, and you should know this by now. Obviously, you from your on-call, from your clinics. It's just another day in clinic, another day on call. If you picture yourself in this environment, you'll be fine. You'll do very well in the clinical skills aspect. And then the fourth is the professionalism and ethical issues with consent. Let's say Bede's case, Jehovah's Witnesses, that sort of things. They can throw some of these, slightly difficult issues on you, and see how you can deal with it. And then, obviously, as we said, you need to be humble, to be polite. This also falls into this professionalism aspects. So this is how you get marked. These are the descriptors. And obviously, it goes from 4 to 8, where 4, you don't know much about the topic, and you can't really apply the knowledge, or you have the knowledge, but you can't really apply it to the scenario very well. You're missing part, important part of the history. You're missing important parts of the examination, for instance. Hernia orifices. Yeah, this is very important. There are many colleagues where the clinical case was a hernia, and they took the case, they did the exam, took the history, took the exam, but they forgot to say hernia orifices, and this is it's done. They lost this station just because they didn't say. If you don't say I examined hernia orifices, they won't volunteer to tell you that there is a hernia, there is a lump, there is a groin.
Femoral hernia exam. Yeah.
Yeah, you won't find the femoral hernia in the groin. They won't tell you about it. Yeah. So again, this is also a 4. If you don't ask about it, you get a 4 for this.
Toes in the groin lymph nodes.
Yeah, that's another thing. And then obviously for the professionalism, you get a 4 if you're rude, if you're overconfident, if you come across as arrogant, that sort of thing. All these things will give you a 4, which you don't want, obviously. And then it goes up the way up to 8, where your knowledge is really good. You know you're up to date with the latest evidence. You know something that the examiners maybe don't know. And then you can apply this new knowledge to the scenarios, and with the twist, they complicate the case for you. You still can, adjust and show this higher level thinking. Yeah, and then your immaculate history taken, the clinical examination, and then as we said, you're confident. But humble and not overconfident. This gives you an 8, and then there is a spectrum in the middle where you get a 5, 6, and 7. So I think it helps to know how you get marked and what are the aspects. And as I said, it's very important not to lose too much time reading all the recent papers about different certain topics, because as I just demonstrated to you, the knowledge part is only 1 out of 4 aspects of how you get marked. Yeah, and you need these papers and new papers, new evidence to get an 8, and you don't need to get an 8 for all the sessions. Really, you need 6th and 7th, and you'll be just fine. Do you want to add anything, Mohammed, before we move to the final?
I would say, yeah, don't get bogged down in it's that line that you have, third line from the bottom. It's being more broad than deep. Knowing the latest evidence and not it's less about single papers and more about latest guidelines. So if you're up to date, this will be your last opportunity to be as up to date across all of general surgery in the rest of your career. So if you're up to date across emergency general surgery, regular general surgery, your own specialty, confidently, safely, without making mistakes or talking without evidence, then that's how you get the 8, not citing single papers and not reading all the books.
Yeah,
that's basically it. So you need the time to practice all of this, and you need the time to read all of this clearly without freaking out and without piling on other things that you don't need. That would be basically the same way. That would be my kind of the things I would like to highlight from what you said.
Yeah. So this last slide is probably pretty much covered all of this. We, book the hotel early, go a day early, a couple of days early, book in the same venue or very, very close by, because in the waiting time between the sessions, between you sessions, there'll be hour and a half, 2 hours, and it's very important to have really good rest and de-stress before your next session. So it helps if the venue is very close, you can go back to your hotel and to rest and refresh. For me also, have some good high energy foods or drinks and keep very well hydrated all the time. Maybe not too much coffee. A little bit of coffee is fine, but not too much. You don't want to be overstressed because, as we said, a very big part of the exam is about how you manage your stress and how you present yourself rather than your knowledge. And I don't think if you pass part 1, I think it's very unlikely that you fail on knowledge. You just need to, if you pass part 1, then you have enough knowledge. You just need to polish this knowledge a bit more, reading about the guidelines and whatever. But I think people fail more because of stress and how they represent themselves on the day. So now is the time to practice how to, manage your stress, whatever technique you have. If you are a religious person, pray, whatever. If you meditate, do the meditate. Whatever your stress management strategy, you just need to practice this before the exam and during these rest times between the sessions. Because it's very, very important, and it's a big part of how to pass the exam is how to manage this the stress on the day itself. And yeah, that's pretty much what I have to say. If you have anything else,
agree with you. How long did you prepare for part 2?
So for part 2, I prepared for about a couple of months. About 2 months, but extensive preparation. So really, really focused about the last 2 weeks, where I had pretty much a practice session with one colleague pretty much every day. I had a session even for half an hour or so, half an hour, 45 minutes, just a couple of scenarios. That's it, but every day. So 2 months of revision, but really, really strong concentrated revision for the last 2 weeks.
And part one?
Part one took me a bit longer. So I took like about 4 months.
Yeah.
But in the beginning, the first month, 2 months, I wasn't practicing every day. So maybe three days a week, 4 days a week, whatever. When I could. But then I focused. I increased the pace stub as the exam approached, and then I took 10 days before the. So I took the week, then with the weekend before as well off. So that gave me about 10 days before the exam, where I just sat at home and just went through the question banks over and over again. So this is what I did.
Yeah, that sounds about right.
Yeah.
It's your opportunity basically to show the community that you deserve to join them and finish your training.
Yeah.
So that change your perspective, and the stress will be less, and you'll be there to showcase what you have and what you know, rather than freak out about it. That's basically it.
Yeah. I think part two, if you well prepared, part two is actually easier than most people think. Part one is pretty broad, and you get a lot of questions about specialties that you don't know, so it's a bit tough. I think for me, part one was tougher than part two. Part two, if you know the knowledge and you practice enough, it's usually you will be surprised that it's actually easier than you thought. But if you're well prepared, then it will be easier than you think.
I think so.
Yeah.
Some said you might enjoy it more, but I didn't have that experience. But I can see what they mean.
Yeah, well, no, not as
No.
much. I know a couple of people who said that they enjoyed it, but no, not for me. It's not. It was all right. It was all right, but it's not as far as I'm enjoying it.
I
No,
wouldn't recommend doing it more than once.
no. Not good for your for the health. No.
No. Lovely. I think that's it. Well done, Mohamed. I think that was very good overview.
Yeah, thank you. That's very good. Thank you for sharing your experience. That's
No.
I think that's a good summary of how to prepare.
Call it tonight. One important resource I would say that's free is the TUGS mock Viva.
Yeah.
And they usually have good like the like really top tier faculty, and it's usually run a couple of times a year, many times a year actually, and you find out about them on Twitter.
Very good.
So that's a good. That's the only thing that I joined up to, and the other thing I would say is getting your previous MDT lists and getting your consultant to go through them with you as cases.
Yeah, that's very good as well. That's a good.
And checking what you would do and talk through them as cases.
Yeah.
Because they also show you the scans in the exam.
Yeah.
That's it.
That's a lot. There's a lot of scans in the exam. There are a lot of even things like physiology. So ultrasounds and all sorts of investigations. So yeah. I got a few MRIs as well, which wasn't fun, but here we go.
I got a lot of liver CTs in my part one. Like a lot of liver CTs. I saw more liver CTs in that exam than my actual job.
Yeah, exactly. Yeah, all of investigations as well. All right, so that's it, and good luck, everyone. I hope this was useful. Thank you, Mohammed, again. Thank you, Amira, for being with us.
Thank you. Thank you both. And if anyone has any questions, they can just send us an email or just on Twitter or our YouTube channel or something.
Feel free to put my Twitter stuff on.
I'll put your Twitter account as well at the end. All right. Thank you.